Let's see, there we go. All right. Well, thanks so much, Rachel, for coming and telling us a little bit about ABA therapy. So I will let you take it away.
All right. Can you guys all see my screen?
Yes.
Okay. Perfect. Just to warn you, I have like an automatic light and sometimes it'll shut off. So if you see me like waving, I'm just trying to turn my light back on so I'm not sitting in the dark. Oh. Let's see here. So just kind of an overview of today's presentation. Some things that I hope you guys take away from it is just an introduction to autism spectrum disorders, maybe a little overview of some of the treatment that is available, and really just the Caribou Autism Health treatment approach to ABA. So what is autism? Autism is a neurodevelopment disorder, typically includes issues with communication and behavior. No definitive explanation, but research is continuing to be ongoing. General consensus is that genetics play a large role and may be responsible for 90% of occurrences. 10 or more genes have been identified that may play a role in autism. One hypothesis that is generally rejected by experts is that immunizations play a part in the increase of autism. So some common symptoms include lack of eye contact, narrow range of interest or intense interest in certain topics, doing something over and over, like repeating words or phrases, could be rocking back and forth or fidgeting with objects, like such as flipping a light switch. It could also include high sensitivity to sounds, touches, smells, or sights that might seem ordinary to other people, not looking at or listening to other people, not looking at things when another person points at them. It could be not wanting to be held or cuddled. It could have problems understanding or using speech, gestures, facial expressions, or tone of voice. Could include talking in sing-song, flat, or robotic voices, or trouble adapting to changes in routine. So taking a look at the diagnostic criteria for ASD, it would include persistent deficits in social communication and social interaction across multiple contexts, restrictive, repetitive patterns of behavior, interests, or activities. Symptoms must be present in early developmental period, but may not fully manifest until social demands exceed limited capacities or may even be masked by learned strategies later in life. Symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. And these disturbances are not better explained by intellectual disabilities such as intellectual developmental disorder. And then so just taking a look at the DSM-4 compared to the DSM-5, some changes were made in that ASD diagnosis. So they removed Asperger's and pervasive developmental disorder, not otherwise specified. And so now only ASD in varying degrees. So level 1, meaning least amount of support, 2, moderate support, 3, most significant need for support. And then there's also social problematic communication disorder. So similar to ASD, but no repetitive behaviors, more communication deficits compared to social communication deficits. So what are some of the characteristics? All autism spectrum disorders have delays and difficulties in 2 of the following areas. So social communication and stereotyped restrictive and repetitive behaviors, interests, and activities. impairment in the use of nonverbal behaviors, so eye-to-eye gaze, facial expression, body postures, and gestures to regulate social interaction, failure to develop peer relationships, lack of seeking to share enjoyment with others. So this could look like lack of showing, bringing, or pointing out objects of interest, lack of social or emotional reciprocity. So looking at the repetitive and restrictive behaviors and interests and activities, could look like preoccupation with stereotyped restricted patterns of interest. Sometimes we see kids that really fixate on, it could be trains, for example, or different TV shows, characters, videos. They might watch it on repeat. Inflexible adherence to specific non-functional routines or rituals. So sometimes we see kids with that very restrictive behaviors. Could be lots of issues when those routines are changed, or if they're not able to complete a ritual the certain way that they're wanting to complete it. Stereotyped and repetitive motor mannerisms. So this could be hand flapping, maybe twisting hair, or the use of vocals. So it could be a noise that they make repetitively, or a phrase that they repeat over and over. Also, we see hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment. So this could look like high pain tolerance, excessive smelling or touching objects, visual fascination with lights. So let's talk a little bit about some of the treatment approaches. So there is ABA, applied behavior analysis, as well as AVB, or applied verbal behavior, which is usually a behavior analyst that specifies in that communication piece. There's also speech and language services, physical and occupational therapies to address motor issues. There is some research out there for a gluten-free and casein-free diet, or maybe other dietary modifications to address food intolerance or allergies. There is sensory integration programs, sleep hygiene and sleep disorder therapies, biomedical supplements to promote healing, decrease inflammation, psychotropic medications, such as antidepressants, stimulants, tranquilizers, etc., to address behavioral problems. Sometimes it's treating comorbid mental health disorders such as ADHD, OCD, anxiety, depression, etc. Hyperbaric oxygen therapy, or HBOT, has been used to increase oxygen supply and decrease inflammation. Relationship building with psychotherapy approaches, and others as well. So I'll go through a little bit of history of Caravel Autism Health. So it was started by two BCBAs in Wisconsin in 2009. Grew to start serving families in Wisconsin and Illinois. And then they began serving families in Minnesota in June of 2019. Currently, we have 10 clinics in Minnesota. We have Rochester, Mankato, 6 Twin Cities locations, and then our newest clinics with the opening of Duluth and Moorhead in the last couple of years. So our goal is really to change lives. So we work in a partnership with families to design customized autism treatment programs. Our programs are rooted in the principles and science of applied behavior analysis, or ABA therapy for short. And we create real world learning experiences to help children with autism and related developmental disabilities build a wide range of skills. So some of the values and principles that guide us here in our company is rigor, just putting in the everyday hard work, compassion for the children and the families that we serve, advocacy, really ensuring that we're providing the highest quality of treatment, hope, just really being driven by that optimism that all of the children that we're working with are making that progress, unity, just working together as a team, not only in our clinic, but also in our communities and really rooting ourselves in the communities and being engaged with other service providers, such as the school systems, preschools, daycares, speech therapy, occupational therapy, any other, sometimes speeding therapy, really any other services that the child might be engaged in, and really trying to come together to provide that really cohesive treatment. Innovation, just we're constantly trying to improve our methodologies and technologies, and just really trying to continue to move the field forward. And then growth, we just really feel to be the best, we need to be staffed by the best. So providing both personal and professional growth opportunities for all of our teammates. So some of the services that we offer at Caravel include in clinic or in home when applicable ABA therapy. So our approach is mostly a clinic model, but there could be certain reasons where we might need to shift to in-home. It could be when we're starting services and we're getting a child into the clinic, or when we are fading out of services and maybe we're focusing on generalizing something to the home, or at times if we've had to not have long disrupts in services, like for medical issue or things like that, where getting to the clinic can be hard. Could be reasons where we move to that in-home approach, but typically in clinic. We also provide diagnostic assessments for those that are needing to get that evaluation to see if they do have that diagnosis of autism spectrum disorder. We also provide, and it's a requirement of our program, is a caregiver collaboration training. So having the parents be involved in that treatment piece. We also provide psychotherapy for families, which a lot can be provided over telehealth with some of our psychologists and therapists. And then we also do consultation with outside services, including school, speech, occupational therapy, physical therapy, etc. So what is ABA? So ABA, or Applied Behavior Analysis, is an intensive therapy that is based on the science of learning and behavior. So ABA therapy can help increase language, communication, and social skills. It can also improve attention, focus, memory. We work on academics or pre-academics for those that are working towards going to school. We can help develop self-care skills. So we have a lot of young children, so sometimes we assist with teaching children to be toilet trained. It could be to dress themselves independently, brushing their teeth, kind of whatever those self-care skills are that they're struggling with is something that we can work on as well. And at the same time that we're working on increasing all of those functional skills, sometimes we work on decreasing some maladaptive behaviors. So really we're looking at behaviors that would get in the way of learning. So this could include tantrums, self-harm, physical aggression, maybe other unsafe behaviors such as eloping from adults or climbing on high furniture. Behaviors such as that, the things that we don't focus on are could be like stimming behaviors, because new research has shown that a lot of the times is to help children regulate. So in the past, ABA might have focused on decreasing something like hand flapping. That is not something that we practice anymore. So we might teach them other coping and calming strategies in tandem with allowing them to engage in a hand flapping behavior that might be working. So the goal is not really to change personalities, just really to give them more functional skills to be able to engage with their family, in school, in the community, and hopefully they'll continue to grow those skills through adulthood. ABA is considered an evidence-based best practice therapy by the U.S. Surgeon General and the American Psychological Association. More than 20 studies have been established that intensive and long-term therapy, so typically 25 to 40 hours a week for 1 to 3 years using ABA principles, improves the outcomes for many children with autism. So typically when we have a child come into therapy, especially one of those younger children, we always take a look at how many hours of ABA therapy is going to be in the best interest of this child learning the most skills in the time that we have with them. And so it is an intensive therapy. So typically we have children here 30 to 40 hours, a lot of times Monday through Friday. And then the overall goal is really to help them develop those skills. And then we reassess every 6 months as they're continuing to make progress in that therapy. And the goal is to really get them to whatever that next learning environment is. So it could be them moving to a daycare setting or a preschool, or maybe they're school age and going to school. And so sometimes we start with full-time ABA, and as they continue to make progress in the program, we might start to decrease our hours and increase hours in that next environment. So then they might do part days in ABA and part days in school, or like I said, whatever that other learning environment is, and then eventually continue to decrease our services and graduate them out of therapy altogether. So like I said, the goal of ABA is to help each person work on skills that will help them become more independent and successful, both in the short and the long term. So to help your child improve their social communication, daily living, and other learning skills through positive reinforcement. So during ABA therapy, baselines are established to set goals, which are then broken down into small steps. And these steps are organized into a logical order and taught one at a time. So how does ABA foster change? We apply ABA with positive reinforcement as one of the primary interventions and methods to increase specific behavior. So when a behavior is followed by something that is valued, a child is more likely to continue that behavior. Over time, this approach fosters the desired change. So how this typically looks in our clinic is conducting what we call preference assessments. So this is going to allow us to learn what items, what activities, what things the child enjoys. And then we use these objects and activities to build motivation to practice those different skills in the center. So this might look like briefly interrupting a child's play, practicing a few skills, letting them engage and play once again. We also partner relationship building and praise with these item activities. So then our therapists also become reinforcing to the child. We really want children to be engaged in therapy by having that positive relationship and enjoying the experiences in the clinic. So a lot of the times when we're working with a child, we're starting out with a lot of play, a little learning, and we just continue to increase the amount of times that we're learning. So really taking a look at the child's age and kind of their abilities. So say their baseline shows us that maybe they're able to sit for 30 seconds and engage in something, and then they're off to the next thing. That's going to be where we start. So we might bring them to the table and really work on those playing with those toys or doing those activities that they enjoy, so that we're building that positive association with that table time. We get to bring our toys to the table. It's fun. We're engaging, providing a lot of praise and attention. And then we might start with just 30 seconds of practicing some of those learning skills before bringing in those toys and activities again. And the goal is really, looking at a child's age, our young children, it might be sitting at the table for a total of 15 minutes. So it's very short breaks where we're short periods of time where we're kind of expecting some of that learning and we're going back to play. And, as the child continues to get older, we're going to adapt that to like whatever is kind of that age appropriate expectation. So you're looking at a school age child, depending on what grade they're in. They might be sitting at the table working on something for 30 minutes. But a lot of times we'll provide short interval breaks of being able to play with those toys as well. So some of our kids have token systems where they might earn 10 tokens and then we move to play. Some of them have duration where they might work for a certain amount of time and then move to play. But all of our learners kind of know what activities and objects are kind of going to get after they complete those learning tasks. So let's talk a little bit about what is behavior. So behavior is defined as the actions or reactions of an object or organism, usually in relation to the environment. So running, walking, saying hello, screaming, kicking, going to work, going down a slide, purchasing a sweater. Those are all examples of behaviors. So we analyze behavior to understand its function and or its communication. And then we implement interventions that will help develop more functional behaviors. And there are a variety of functions. So a few of those could be escape, avoidance, access to tangibles, attention maintained, automatic reinforcement. So an example of a behavior that is maintained by escape or avoidance could be running out of the classroom during math because the student struggles with math and they're wanting to avoid that situation. An example of a behavior to gain access to tangibles could be, the child screaming and crying, having that tantrum in the checkout line so that their parents will buy them that candy bar. Maybe that's happened in the past where they threw that tantrum. It was embarrassing for the parent, bought them the candy bar to quiet the child. That's their learning history, right? They've learned that candy bar or that behavior will get them that candy bar. An example of a behavior maintained by intention could be interrupting parents when they're on the phone, maybe to show them something that they've made. A lot of the times as a parent, you might go back and forth, you might stop what you're doing, give them that attention. So then they're kind of learning that's been reinforced in the past. An example of automatic reinforcement, this could be a child like screaming in an empty room because they like to hear their echo. Something that doesn't require another person, another object, or any kind of attention. So this behavior could happen when they're completely alone. So when we talk about behavior in ABA, we look at what we call the ABC. So that stands for antecedent, behavior, and consequence. So the antecedent, which is made both of motivation, degree of willingness, and instructions, evokes your child's response. The consequence that you deliver will either strengthen or weaken the likelihood that your child behaves the same way in the future. So an antecedent is what comes before the behavior. This includes motivation and instruction. Motivation is your child's willingness to learn. Your child will want to learn because he or she is motivated by the availability of the reinforcer. And instruction is the actual demand that leads to the particular response. This could be a request, such as put on your coat, or it could be an environmental demand, such as everyone is sitting down at the table for dinner. The child needs to be motivated and needs to understand the instruction before he or she can be expected to respond correctly. Behavior always serves as a function. It is a purpose. It is purposeful to your child, and he or she is trying to communicate with you. Behavior is anything that happens after a particular set of antecedents. When looking at behaviors to target for change, we need to target specific responses that you are trying to teach. We call these replacement behaviors, or it could be a challenging behavior, which would be any non-target behavior that get in the way. So those things that we talked about earlier that get in the way of learning, things that we might be looking at decreasing. So there are behaviors that we're looking at increasing and behaviors that we're looking at decreasing. Once you identify the target behavior, you can prompt your child towards success and avoiding those challenging behaviors. A consequence is what happens after the behavior. So there are 3 types of consequences: reinforcement, punishment, and extinction. So reinforcement is the delivery of something your child finds pleasant. Like maybe you give them a sticker, or the removal of something your child finds aversive. For example, maybe you tell your child they don't have to do their chore that night. And that strengthens the behavior. So this is something that would cause the behavior to happen more often. Punishment is the removal of something that your child finds pleasant, or the delivery of something that your child finds aversive that weakens the behavior. So this could be, taking away the iPad, or an example of delivery of something your child finds aversive. Maybe you give them an extra chore. And that is going to decrease the likelihood that that behavior continues. And then the last one, extinction, is when you no longer provide reinforcement for a behavior that has been reinforced in the past. So this will eventually weaken the behavior if done consistently. So here's an example. A demand is placed on Jack. Jack, it's time to come eat dinner at the table. That's the antecedent. Then Jack kicks, screams, flops to the floor. That is the behavior. Then parents hug Jack, remove the demand, not requiring Jack to come to the table. Jack's tantrum has worked to escape the demand. The tantrum has then been reinforced. This is the consequence. So here's another example. The antecedent is Susie is hungry and indicates she wants a banana by pointing to it. Mom then holds out the banana in front of Susie and waits for Susie to say, banana. This is the behavior. Susie spoke an approximation of the word banana and got what she wanted. The vocalization was reinforced. This is the consequence. So you can kind of see both sides, how we might be reinforcing negative behaviors and how we can use the same concept to reinforce the behaviors we want to see. Principles of ABA are at work all the time. You work for a paycheck. That's reinforcement. You get recognition from your significant other for something and then are more likely to do it again next time. Also reinforcement. You do more of what your boss praises you for. Reinforcement. Maybe your partner no longer states her appreciation of your efforts to clean the house, so you lose the desire to keep trying. That could be extinction. You ignore Billy's pleas for candy at the store, so Billy stops asking. Extinction. So now let's go into a little bit of how ABA therapy looks in the clinic setting. So therapy begins with a comprehensive baseline assessment. And this is to evaluate the child's skills and abilities compared to same age peers. So typically, there's a few different types of assessment that we might use when we are, depending on like the age of the child, or kind of what we're looking for. But most of the assessments will take a look at their social skills, their cognitive skills, self-care skills, all of those different things that we talked about earlier, and kind of compare it to their same age peers so that we can kind of really see where we're at. Testing typically includes direct testing, observation, and interviews with caregivers. This really helps us get a very comprehensive picture of the child, and allows us to kind of make those treatment recommendations, such as how many hours of ABA therapy the child would benefit from, and what type of therapy goals should be worked on in treatment. So every child has a very individualized treatment plan. So we have typically, I would say each child probably has 15 to different goals in all of those categories we talked about earlier that they're working on. And then we kind of break those down into smaller steps. So the baseline assessment is used to develop those individual sets of goals in those different areas: communication, social, self-care, cognitive skills. And then, like I said, they're broken down, and they're practiced every day during the child's therapy sessions. We also write the treatment goals are also written with the plan that every child will accomplish. We usually aim for about 80% of all of their treatment goals within 6 months. We really want the child, the family really to see that success. So we really shoot to be able to accomplish those goals rather than overshooting and having the same goals for those prolonged periods of time, because we put goals in that were maybe too difficult. And then every 6 months we reevaluate by conducting another assessment. So then we can take a look at the child's progress, and we can determine maybe what goals should be worked on next, when to begin fading or graduating out of ABA therapy, or increasing in those other learning environments. So what does therapy look like? Typically our centers they're set up like classrooms. So the classrooms are usually filled with toys, fun activities, and learning materials. All of our classrooms typically have a schedule that they follow that might circle through individual learning times, different group activities such as art, music, story time, and then different play times. The individual learning times focus more heavily on those cognitive, self-care, and communication skills, where those group activities can help foster the social and communication skills. And then playtime for natural breaks, reinforcement, and then really building those positive relationships with the providers. So who is on the child's team? So there is the Board Certified Behavior Analyst, or BCBA. They are a master's degree level clinician who have completed a rigorous certification program. The BCBAs oversee the therapy team who guides the child through the individualized therapy plan. The BCBAs complete the assessments, they complete the treatment plans, they lead parent and caregiver trainings, and provides staff supervision. We also take data on all of our treatment goals, and it's really the behavior analyst role to analyze that treatment data and to ensure that that child continues to make progress. And since we know that every child learns differently, if we see that a child is kind of stalling out or really struggling with a program, that's really an indicator to the behavior analyst that they need to do some deeper digging into what might be causing that. So it could mean providing more support for the teammates, making sure programs are being ran correctly. It could mean needing to teach that child that program in a different way. So maybe they rewrite the program, they go back out and train and continue to monitor that treatment data and make sure that the child is continuing to make progress. Or it could mean that there's a prerequisite skill that that child needs to learn before they're going to be successful for that program. So then they might go back, put that program on hold, teach that prerequisite skill. And then once they have that skill, then they can go back to the previous goal. We also have our registered behavior technicians, or RBT for short, and they complete a 40-hour training series and pass an exam to become certified. And the RBTs provide the individualized therapy to the child. So they're interacting with them directly to engage them and help them learn. RBTs build a positive and familiar rapport with the child as they continue to receive guidance and support from the BCBA. So the RBTs are really doing that one-on-one work. Typically, each child will have a couple of different RBTs trained on them. And the reason that we have more than one person providing therapy is we have seen through the data that the more adults that child is practicing with, the longer they're able to retain those skills. Sometimes the quicker they pick up on the skills, and more importantly, the more they're able to generalize them to other adults in their life. So if they're learning with multiple adults at the clinic, then we see them generalize those skills to, say, teacher, parents, babysitter. Whereas if we don't practice those skills with multiple different adults here in a clinic setting, sometimes we see that not generalize or happen at a much slower rate. The last piece, really that's a big part of ABA and especially here at Carabel, is that caregiver collaboration training. So this is used to generalize skills work on the clinic to other learning environments such as home, school, community. It could be used to work on family-specific goals. Maybe the child is struggling with a morning or bedtime routine or toilet training. And we can go in the home and teach families on these programs that we're running so that they can successfully run them in the home so that their child continues to make progress. We also use these to update caregivers on child's progress in therapy, as well as maybe problem solving any barriers to the child's progress in therapy. And the reason that we call it caregiver collaboration is because this could include teachers. It could include, like, if they have any direct care support professionals or sometimes grandparents. So it really is not just meant for parents. It's really meant for helping kind of anyone else that is in that child's life, so that way we can really help them be successful in all of those different learning environments. Well, I know I went through that. I felt like it kind of went a little fast. So questions or anything that I need to clarify, I can always go back.
Yeah, I have a few questions. Let's see. I guess my first question is, how does one qualify for ABA therapy?
Yeah, that's a great question. So typically it starts with that diagnostic evaluation, so that they can have that, make sure that they have that autism diagnosis. And then typically the psychologist or that does the diagnosing will make the recommendation. And a lot of times the psychologist might make a recommendation of how many hours. Typically around here, a lot of them just kind of recommend those full-time hours, because they know that the behavior analyst will complete a more intensive assessment, and it could recommend if they think that the child might not need a 30 to 40 hours if they can make progress with, 15, 20 hours of ABA therapy. So that is kind of the starting point, is getting that diagnosis, or it could be that related diagnosis. There's a few other diagnoses like certain cognitive delays that could also qualify for ABA services. And that's specifically in the EIDBI program. There is ABA that's used in schools that might bill other codes. I know some schools have, not with Caravel, but with other providers in the area, might have like private contracts to work on like behavior reduction with children who might struggle with behavior challenges in the school as well.
Oh, okay. Um, let's see. I think that'll lead into my next question. So the therapy is pretty lengthy, like 40 hours a week is, I mean, even 25 is quite a bit. So like typically, how does that, I mean, maybe, okay, so I have two questions. What's the average age of a kiddo in ABA? And then like I feel like that bleeds into like the length because if they're in school, I'm sure that looks a lot different. Or do they, how does that work, I guess, with age and length and other services that they're in?
Yeah, that's a great question. So typically we always recommend early intervention. So like the majority of our early intervention kids are probably between the ages of 2 and 4. So it's that preschool age. And what we see when we do have kids, even that young, kind of really engaged in therapy, and really I look at it as it's probably about the same amount of time they spend in daycare. There's a lot of play activities and things like that. Parents are not required to be here during those 40 hours. So it's they drop off, they pick up at the end of the day. Parents are really only required to do, we require about 2 hours a month of that caregiver collaboration training piece. And that's the piece where we'll focus on them in therapy. But when, working with those young children, it's a lot of therapy based on play. So they don't see it as like they're sitting at a table all day or things like that. It's very fun and engaging for them. And typically when we're working with those young children, by the time they're school age or even before, a lot of times we're transitioning kids to start preschool, so that there's not like that delay in starting school. We do also have a fair amount of those kids who did not get that young early intervention that might be like 5 or 6. And so we can be typically some of our kids come to us instead of school. So, it might be like age 7 where they start to kind of mandate that in school. And even then parents can choose to essentially homeschool and then put them in our program. And we have a good relationship with the schools here as well, especially in Moorhead. I have just started working with some of them in Fargo as well. But typically that handoff and that transition back to school goes very smooth. Because what we really look at is like those prerequisite skills for school. And what I explain to families and teachers is sometimes when we have kids that, when you look at what are those prerequisites? They need to be able to sit for a duration of time. They need to be able to orient towards a speaker, follow simple instructions, follow a routine. So those are the things that we can work on. So that way, when they transition back to school, so those are kind of the skills that they need to be successful in school. They're going to get a lot more out of it. So even though they might be missing some school in the short term, we're setting them up to get more out of school when they transition. Rather than just by putting them in school before they're ready, they might just continue to get behind.
Thank you. I know that was kind of my question was, are kids going there, instead of going to school? And because what is the typical age of when a child is diagnosed with autism?
So they can be diagnosed as young as a year old. And different I think we've done some education with providers in the area because I know a lot of families had told me like they talked to their doctor and they had told them to wait, that they were too young for that diagnosis. And what we really see is that early diagnosis is key to them getting access to those services that is going to put them at a better spot, for being able to learn those things early and not constantly not playing catch up. But yeah, they can be diagnosed as early as a year. I would say the area has a lot of providers that are really doing, I think, getting more education and being able to better. I think we're just getting better at diagnosing.
Mm-hmm. Okay. And then I have another question that's like on a way different tangent, but at the beginning you talked about like diet and inflammation. How does inflammation like play a role in autism?
Yeah, that's a great question. And I probably can't answer it as better as like maybe a doctor, but there's no like links to say anything about causation, but there is some very interesting correlations between autism, some of those behaviors that we see, and gut health. Whether that is because children on the autism spectrum have those restrictive, repetitive behaviors that we might also see impact what they're eating. So, I work with families that the only thing their child will eat is chicken nuggets or cereal, or, so we see how that could probably play a factor in their gut health, which can cause, when your gut's not happy, when your stomach hurts, it can cause other behaviors and increases in those behaviors. So those things in tandem to other services can be helpful. But there's also interesting research that talks about whether or not that it could be an opposite correlation, right? That some of the issues that some of the gut health issues might be impacting some of the behavioral issues. Fascinating research, but it's kind of correlation, not causation, because you can't really prove one way or the other.
Yeah, it is interesting. I was just wondering, I kind of figured, but yes, I know I did a little webinar of myself on like food dyes, and a lot of it talked about the behaviors and stuff, and it is really interesting. So I just thought I'd ask. Did anybody else have any questions?
I do not. It was all very good information though, so thank you.
Yep.
Thank you guys for having us.
Thank you so much. We will get this posted on our website for families to go back and access, but this was all very wonderful information. Like I said before, I knew nothing about ABA, but I've heard it like in team meetings and stuff, so it's good to finally get a better grasp on it.
Well, and if you guys have any families that are seeking more information, feel free to give them my contact information. I'd be happy to talk through any of it with them, or even give them a tour of our center if they wanted to learn more.
I do have one last question.
Yeah.
So, and it kind of ties with my first question about qualification. Does one have to be on the autism waiver? And I don't know if Minnesota is different than North Dakota, but does a child have to be on that to receive ABA?
They do not. No.
Okay.
Well, I shouldn't say, a lot more insurances are covering ABA as a medical necessary service. So some insurances might have like a copay. Other insurances, like MNMA, cover it 100%. As of right now, we don't accept NDMA, just because the reimbursement rates are very, very low. But we are working to help advocate that NDMA increase their reimbursement rates so that more providers are able to accept them.
Okay. Okay, that's good to know. Thank you.
Absolutely.
Well, thanks so much. And yeah, we'll get this posted.
Thank you guys. Have a great holiday weekend.
You too.
Thank you.
Bye.
Bye.